into the room. So let's give this a couple more minutes. While we're waiting, I want to remind everybody that attendees should be muted throughout the session. We're going to keep everybody muted. We are going to be doing some questions, so you can use the chat feature. You can also use the email address that we've set up at info@butler-benefits.com. We're going to have an immediate Q&A at the end of the session. So if you've got questions, just please use the chat function. We'll take those and answer as many questions as we can at the end, but give us a couple of more minutes while people trickle in here and we'll get started. Thank you guys for being here this morning. Okay, it's a couple of minutes past 9 o'clock. Deeter, Elliot, Dr. Libby, can you guys hear me okay?
Yes. Okay.
Okay, great. Well, we're going to go ahead and get started with our presentation this morning. My name is Josh Butler, and I'm the president of Butler Benefits and Consulting here in Amarillo. We are a healthcare consulting firm and benefits brokerage firm. And we're really focused on fixing some of the more challenging problems that we face in our healthcare system. As you all know, there's many problems in our existing healthcare system, and we believe that a lot of solutions exist out there. And you know, we're going to talk a little bit this morning, but first, I just wanted to kind of make a couple of comments. This past year, healthcare spending in the U.S. rose another 5%, reaching $3.6 trillion, which is $11,172 per person in the U.S. And that constitutes approximately 18% of the entire gross domestic product in the U.S. And that's really remarkable figure when you think about it, that 18% of GDP is spent on healthcare in this country, which is $3.6 trillion. Research also shows that 40% of all health expenditures are either unnecessary, fraudulent, or wasteful. And that's a big number. So that equates to about $1.4 trillion per year on healthcare, and that's either unnecessary, fraudulent, or wasteful. And so needless to say, we know that there's a lot of room for improvement in our healthcare system, which is kind of what's led us to this conversation today. I'm very excited about today's conversation about direct primary care. And not only because I think it's going to further benefit our clients, but I think it's a solution that's really going to benefit our community at large. As I mentioned, the topic is direct primary care, and as you'll hear us talk a little bit throughout the presentation, DPC is how we just use the acronym. Many of you who know me know that I'm very passionate about DPC, and I have been for several years. I believe it's one of those solutions that in healthcare that truly achieves the triple aim. And in healthcare, we consider that to be better quality care for patients, lower prices and costs for employers and their employees, and ultimately happier and healthier doctors as well. So today we're going to kind of dig into those three things a little bit deeper, and hopefully everybody will go away with a better sense of what DPC is and how we're utilizing it to lower cost for patients and employers, and also at the same time provide higher quality outcomes for people. So I'm also extremely excited to introduce my friends and colleagues from Medical Dojo this morning. Medical Dojo is Amarillo's premier direct primary care practice. Dr. Libby Ellington is a partner at Medical Dojo, and we're going to give her an opportunity to tell us a little bit more about herself in a second. We also have Deeter Prater with us this morning. He is also a co-founder of Medical Dojo. Good morning, Deeter.
Hello.
And then also Elliot McKinney, the other co-founder of Medical Dojo. Good morning, guys. Libby, I want to start with you. If you'll just take a moment to kind of introduce yourselves and give us a little bit about your background and tell us a little bit about Medical Dojo and why you guys decided to, get together and start a direct primary care practice in Amarillo, Texas.
Okay, good morning. Thanks everybody for being here this morning. I'm Libby Ellington, and I was born in Atlanta, grew up in Houston, and I'm a TCU Horn Prof who then went to medical school in San Antonio, did my pediatric residency in Dallas at Children's Medical Center of Dallas and Parkland. They were pretty much affiliated at the time, and we kind of ran the nursery there. Practiced general pediatrics for a year after that, doing basically community health, and then did some private practice for a couple of years, went back and did a fellowship in developmental and behavioral pediatrics at Texas Scottish Rite Hospital in Dallas, and then moved here to the Panhandle, and I've been here for 20 years. And I ran the developmental behavioral clinic at Texas Tech for a little while, and then stayed home and raised children. So I think that was a big part of my pediatric training, was 10 years of on-the-job child rearing, and raised 4 daughters. Just about got the last one out of the nest, and got another year to go. But I went back into practice almost 8 years ago, and realized at that time, just in the 10 years I'd been out, that medicine had changed dramatically. And we used to be able to have time with our patients. We used to get to know our patients. We used to have doctor-patient relationships. I knew their families, knew where they wanted to go to college, knew all about them. And then all of a sudden, medicine pretty much changed, and it was more a conveyor belt, and you're in and out and moving them through, and that's just what you kind of had to do. And I think that's a combination of reimbursement and what we were pretty much expected to do to continue to pay the bills, but it was also because there was a lack of primary care providers, that there was just such a demand that we had so many patients that we had to see. So we were just moving them through so fast, and I just realized this is not what I want to do. So since I went back into practice 7 or 8 years ago, I've been looking for a solution, another way to practice medicine, another way to be available to patients and to help make a difference. So a friend of a friend kind of connected me with these two guys, and what we've come up with is something I feel is pretty fantastic, and it's going to be a big benefit to the Panhandle.
Absolutely. Thank you, Dr. Libby. Deeter, Elliot, you guys want to go next?
Yeah, sure. Thank you, Josh. First and foremost, just thank you for putting this on. Really appreciate it. You've kind of been the glue to a lot of this, really. So thank you. My background is, I've been in the health insurance game for a long time, last 20 years. Started as an insurance broker, and then, moved into the last 15 years, really medical cost containment at different levels. And I just have a passion for healthcare in general, really do. And when Elliot and I, we originally met with you, Josh, almost 2 years ago, and we started having these conversations, and then Elliot and I literally started traveling the country, meeting with practices, good ones, bad ones. What do we like here? What do we not like at this one? Why do they do that? What's the best model? And so, we built internally what we felt like was the best model, and then we went out and we started physician recruitment, which turned out to be the absolute hardest part of this entire venture for Medical Dojo. We had a high-priced, headhunter firm that had 0 hits, and literally, as Dr. Libby just said, it was a friend of a friend, and I would really call it divine intervention. I really would, and it just came together, and literally within the first 5 minutes of Elliot and I meeting Dr. Libby, I knew right then. I was like, she's perfect. We didn't hire. We had a very vast, various focus group on DPC and who would buy it, who wouldn't. And we got a lot of answers from that group, which were fantastic. And really, Dr. Libby became a unicorn for us, meaning pediatrics. So that's a very huge win here for the community and the Panhandle, because not a lot of practices have that. Even the DPC clinics around the country that Elliot and I, visited with, they didn't have that specialty. So Libby really is a unicorn in that regard, and we feel like it's just gonna, really help us be successful. So we're really excited about it. Thank you again, Josh, for doing that.
Absolutely, great to have you, my friend. Elliot?
Hey, good morning, everybody. I woke up this morning so excited about the topic. I was thinking maybe we could flip this content to Netflix. They're so desperate. They may be a buyer. So, and I would like to emphasize what Dee said regarding Josh putting this together for us. It's been 2 years, maybe a little longer of just kind of some fits and starts, and everybody stayed committed and focused, and really bringing this group together has been it's kind of a cool story, because we did what you should normally do from a technical standpoint. We did everything we thought would be appropriate from the technical side, and then voila, here we all are. So I'm born and raised in Amarillo, went to WT, graduated from WT with an accounting degree, and most of my experience is in that area and in operations. And so we feel like this group together, puts together some unique tools that we can help kind of change the way people experience medicine. So we're really excited about it. Thank you.
Yeah, absolutely, guys. Thank you guys so much for being on and helping further educate our clients and our colleagues and friends and everybody that's with us this morning. I really appreciate it. It's been a fun journey with you guys, and it's finally coming to fruition for Amarillo, and I'm really excited. So let's kind of dive in a little bit here. Before we start talking about a lot of the problems that direct primary care in general solves, let's first kind of just talk about some of the bigger problems or the bigger issues that a lot of patients face, and frankly, that a lot of health plans and a lot of employers face as well, especially when it comes to primary care. And just feel free, you guys jump in, whoever feels inspired to kind of tackle one of these issues. It doesn't have to be assigned to anybody, just kind of jump in and weigh in. But one of the biggest issues that comes up is wait times. And what I kind of find pretty shocking in the US, because of the doctor shortage we have, especially in primary care, is that the average wait time to get in to even see a primary care doctor if you're a new patient is 6 days. And so as I was kind of trying to absorb this statistic here, it really just made me think about coronavirus and the situation that we're in right now, that everybody's in, and we're sheltering in place. And I don't know of a human being on the planet that is starting to present symptoms of COVID-19 that's going to wait 6 days to go see a doctor. So talk a little bit about this as it relates to consumer behavior and patient behavior. And Dr. Libby, if you want to jump in first, and how big of a problem is this for patients?
Well, 6 days is unacceptable if you're sick. If you wake up feeling bad, you want to talk to somebody. You want an answer. And I know in pediatrics, little children can go north or south very quickly. And what I mean by that is they can change their clinical picture very quickly. So they might wake up with a fever this morning, and by the afternoon, maybe they're great, or maybe they worsen and 6 days, you can't wait to just have a kid seen. That's one problem with the 6 day wait. Another problem is, could be the presentation of a chronic disease, and maybe somebody wakes up and they've got a rash, and 6 days from now it's no longer there, but maybe it was a clue to something more significant that they have, and you've missed it now. So those are two big things that come to mind when I see an average wait that's that long. But then if you put it into perspective and what we're experiencing today with COVID, if they're told they're not going to be seen for 6 days, they're going to the ER, and you're going to have ER charges, and which could definitely be avoided if they had a primary care contact, someone they could call that could address their concerns. And a lot of times it's just calming them down, it's just talking them through their symptoms. But if you don't have that contact, you're going to reach for whatever you got, which might be the ER.
You know, that's a great point. When I read in a little bit deeper into this statistic here, you know, if the average wait time is 6 days, or even if it's 3 days, or even, you know, just multiple days when people are feeling really crummy, you know, that's the #1 reason that people actually present to an emergency room, is because they couldn't get in to see their primary care doctors fast enough. So as far as like time, you know, components here, let's just kind of go to the next one. And if you guys want to talk about this comes up quite a bit, is just average response time. So a lot of times patients want to follow up, they have additional questions, maybe they forgot what their conversation, the specifics of the conversation was like. And so when patients are asked about their points of frustration, the average response time from a doctor's clinic in the US is 3.2 days as well. So kind of talk about that a little bit. What factors do you think contribute mostly for doctors and for clinics, you know, for this such a slow response time?
I mean, I think sheer volume. I think when they're busting through 50, 60, 70 patients a day, and they've got nurses running left and right, I mean, just trying to keep up with what labs were ordered and who got what, and did they come back, did they not come back, do we need to find out, you know, call the lab and find out why we don't have this result. I mean, when you're just dealing with sheer volumes of patients, it's hard to track all that and to keep up with that. So, you know, 3, 4, 5 days it might be before you know the results of your lab that you had done, you know, at your previous visit.
Yeah.
Josh, you know, another, you know, analogy of that response time is most of us as, you know, working professionals, you expect some reasonable expectation that, you know, you're being communicated with at least in a 24-hour period. And we're talking about healthcare right now, you know, probably the most real and important thing to each individual here. And that concern, you know, deserves, you know, professional, rapid communication. I mean, it's just pretty basic. It's just kind of the blocking and tackling and taking care of people and delivering good service.
Right, and you had mentioned, both you and Deeter had mentioned a little bit earlier about how you had a focus group that you utilized, and you also, you know, spoke with many, I know you guys spoke with many DPC practices around the country. And so I think another thing that really contributes to the wait times and the response times is talk to us a little bit about, in the fee-for-service world or in the status quo world, what's an average patient panel size for most primary care practices and why that matters?
In our experience, talking to different healthcare providers, they can run as, you know, 2,500 to 3,500 patients, and that's just, you know, that's just too much. You have to slow down, and it sounds a little cheesy, but you have to put the care back in healthcare. You know, it's just too big of a load. I mean, Dr. Libby, you know, mentioned it. It's just going too fast, and you're spending 7 to 9 minutes with a patient on average, just because you have to, because of sheer volume. It's a very difficult situation for everybody.
Yeah, Libby, tell the story of, we talked about the other day about checking the box and then someone coming in with a list.
Oh, yeah. Well, in my practice experience, you know, the nurses typically put the patients in the room, and so they might give you a heads up before you go in. They say, you know, oh, you know, Johnny's got a fever, or, you know, Susie's throwing up, or whatever. But I have had many experiences where the nurse would put them in, and she'd just be like, oh, beware, they've got a list. And, you know, I tell my mom that when she goes to the doctor. I'm like, okay, make sure you write down all of Dad's problems, and so that you can talk and have them all addressed. And I just know when they walk into the doctor's office, that doctor's going, oh my God, it's one of those patients with a list. And, it used to give me anxiety because I knew that I had 20 more patients lined up behind this patient I was going in to see, and I had 5 to 7 minutes to get in there, see the kids, make a decision, and move on to the next one. So you would have to kind of pick out the thing maybe on the list that was the most pressing at the moment and gloss over the other things and, hope that you got close enough to meeting their demand and tell them to come back. So, then you're setting them up for another visit in another week or two to address the other issues. So we would laugh and we would be like, okay, you might have a list, but, one problem a day, that's all you're allowed. And so, this new model is a completely different way to practice medicine. And it's treating the whole patient. It's knowing what's going on with every system in the patient, from their stress level to their mental state to their physical state, and they all interrelate. And if you're not addressing all of them, then you're not really addressing any of them. So it gives you the opportunity to know the patient and to address all of their needs.
Yeah, in a way, and I'll kind of wrap this part up, Josh, but in a way, to me, like you're reintroducing the doctor to the patient and you're really forming a meaningful relationship. That's really how this thing used to be before any insurance or fee-for-service was created. The doctor had a real relationship.
And that's why we went to med school, is to develop those relationships and to have those experiences.
Yeah, and I think
Sorry, did you
No, that's good.
No, it's good, and it's a great story because you're right. I think it's important though to kind of really emphasize at this point of the conversation that when we look at these average wait times of just 12 minutes in situations like Dr. Libby just described, that it's a systemic issue. It's not an issue with any particular doctor. I know doctors are passionate. They get into medicine to do good, to treat their patients. And then, they get in and they're in this big system, right? And it's the fee-for-service system where they're paid and they're rewarded more by volume than they are more by value. And so I think that's why you see like a lot of different payment models are starting to shift over towards value-based payment models versus quantity-based payment models. I just think that's a really important issue because we know doctors care about their patients. They're forced to work within a system where they need to see that 65, 75 patients a day to make ends meet. And it leads to doctor burnout. It leads to lower quality care for the patient. It's just not a good delivery model all around. And I think we would all agree with that. So the last thing that I kind of want to get into as one of the primary issues that we can dig into a little bit deeper is we all know that, cost is the #1 overall barrier to quality healthcare in this country. And that's been exacerbated by this big migration over into high deductible health plans, and which, just shift cost over onto patients more than reduce costs. They just shift cost. And so let's talk, we're going to talk a little bit more about cost as we move along, but we're going to kind of, address, these issues, and more specifically how Medical Dojo and DPC as a practice in general kind of addresses these major issues. So let's first just define for everybody, what is direct primary care? And, we can go to a textbook definition, but basically it's a different model and payment system where patients and employees typically pay like a retainer or a membership fee directly to the doctor or the clinic or provider in exchange for access to a broad range of primary care services. What I find very interesting is statistically, 80% of a person's healthcare needs can be taken care of by a primary care doctor. So just in their clinical training, they have the ability to treat a lot of different things and see a lot of different types of patients. But beyond this definition, you guys talk to us because y'all mentioned some services that not every DPC clinic in the US provides, but talk to us a little bit about some of these adult services and adolescent services that you provide, and that makes Medical Dojo a little bit different. And whoever wants to kind of jump in there first, Deeter or Elliot, you may want to jump in first on this one.
We're not doctors, Josh.
Neither am I, Deeter. Neither am I. So But
well,
just,
I'll just say, yeah, that what we're offering for our patient panel is they will have an annual physical as part of their membership, and in addition to just the extensive evaluation that they will have for their physical, we set aside at least an hour for every patient. We want to know all about their lifestyle. We want to know their stressors. We want to know what they do for a living, what their medical problems are, what their concerns are, and how we can best help them. And in addition to the physical and the history, we do a medication review, which a lot of times results in cost savings, because we find that they've been taking some medications for 5 or 6 years and they don't know why they're taking it, and they probably don't need it anymore. And by reviewing and going through those, we can sometimes realize that there are medications that can be cut and costs that can be saved in that way. But we also, as part of their physical, they receive their annual screening labs at no cost. So we do a CBC, a CMP, a lipid profile, urinalysis. All of that is basically free of charge to them. It comes with their membership. And so that's a nice advantage for them. For pediatric care, when they're little, they require periodic pediatric wellness exams and developmental screening, and that is part of the service that we provide. They, in their first year of life, they see the doctor, let's see, when they're a few days old, 2 weeks, 2 months, 4 months, 6 months, 9 months, 12 months, so 7, 8 times a year, and that's if they don't get sick. And the average child under 2 gets 8 to 10 URIs, upper respiratory tract infections, a year. So you add all of that together, and the cost becomes it becomes pretty striking that we become a bargain to a parent with a small child. And we are dedicated to seeing that family, and we know that family, and form relationships with the family.
great, excellent.
Okay.
Go ahead, Elliot.
I was just going to say, part of the cost, we touched on that slide before, but with the high deductible healthcare plans, if it's whatever it is, $1,000, $1,500, $2,500, and they go up from there, if it's the first dollar, the first dollar is out of pocket. And I know for children, most parents are not skipping out for the care for their children, but for them, if they become sick or something, they may just choose to kind of look over it or ignore it, hoping that it gets better, and that there might be underlying conditions. And this removes that barrier. There's no copay, there's no deductible, there's nothing like that. You receive all these benefits that you have listed here at no cost when you show up for the visit, either virtually or in the clinic.
Yeah, that's great. And we also know that pricing was going to be one of the early questions, and so we wanted to get that up pretty early. But as we go through that, it's not just a different delivery and finance model that you guys are talking about, the difference between a membership model here and the fee for service. So when to kind of stay in that vein, Elliot, with people with high deductible health plans, maybe looking and saying, well, a doctor visit's only about $120, but a lot of times, when people go to doctor visits, they need to go for labs. Doctors need to do some diagnostics. They need to maybe have a CT scan done, or especially lab work. That's a pretty prevalent deal. So when you add in the cost of those things, that just gets folded into your membership. That's pretty valuable for patients. So Deeter, talk to us a little bit more about how, we talked about and touched on this, about how the fee for service model is it's really fundamentally misaligned with quality care for the patient. And then let's also transition into the financial misalignment that fee for service poses versus a capitated model like membership fees and things like that.
Yeah, I mean, this whole thing really, if you keep it simple, is you're taking a current variable expense and you're making it fixed, okay? Like for example, I took my son to the doctor 3 months ago. He was sick. I have a high deductible health plan, which means it didn't pay anything. It was, Blue Cross Blue Shield. I literally paid $335 out of pocket for no lab and an office visit of less than 15 minutes. That drives me mad. And so it's not like I'm not the only person out here that deals with this. And honestly, like I got sick back in February and I called to get in and I didn't have a 6-day wait like your earlier slide showed. It was actually 12 days. And I knew in 12 days I was either going to be well or dead.
Yeah.
So I gave up and I just went to Walgreens and I self-medicated. And, you know, I think we've touched on the fee-for-service portion enough.
Yeah.
But again, like we're delivering a more intimate care here. Like this really is the quarterback of your care. We want to get to know you on a personal level. What's going on with you? And how do we how do we help you become honestly the best you?
So that's a great point, and I think I agree. I think we've touched on the kind of the payment models, enough here. But when you talk about these time differentials, I see that when doctors are given enough time, the time seems to be like one of the biggest issues here. Like for me personally, I was, recently diagnosed with sleep apnea, which nobody had ever even talked to me before. But because I had gone to a direct primary care doctor, and it was 45 minutes into a 60-minute consultation with my doctor, that I discovered that I had some pretty severe issues going on. And since then, she was able to treat me, and I feel a whole lot better, and it's made a big difference. So Dr. Libby, talk more about, your ability, what it means to you as a care provider to just have that time and where that can go and how it relates to people with chronic diseases and, more complex comorbidities when you're just given enough time to treat your patients.
Well, and I think I touched on that just a little bit earlier when I mentioned that you want to know everything about that patient, and that certainly can't be done in 10 or 12 minutes. And to really treat the patient, you need to know what's going on in their lives. You need to know, like I mentioned before, and kind of that ties into our name, Medical Dojo, which we'll get to here in a minute. But we want to treat their mind, their body, and their soul. We want to know everything that's going on with them from the inside out and be able to treat that. Having the time with them helps to tease out. They might not know what's wrong with them. They just know they're feeling crummy. And if you talk to them long enough, you can ask them enough questions to find out what it is that might be making them feel bad. And it just, sometimes that takes a while to develop their relationship, develop the trust, to be able to actually get to their key issues. I can't tell you how many times I've seen a patient and we think we've diagnosed them, we think that we're doing what's best for them, they walk out the door, and as they're walking out the door, they'll say, oh, yes, and by the way, such and such. And you're like, oh my goodness, if they had mentioned that to begin with, that would have changed the whole course of where I was going with this treatment plan. But they're mentioning it on the way out, and if you've got an hour to sit there and really talk through things, then you're gonna treat the patient the way they need to be treated.
Josh, this topic right here also speaks to cost as well. The financial aspect of it is if your care provider, your primary care provider, which is the quarterback of the system, if they can spend the time that's needed, not required, that everybody needs, they can properly, diagnose and most likely treat in the clinic versus, well, that sounds like something for such and such down the street. And what I'm talking about is referring them out to specialists that, in the healthcare system, that's just a downstream cost that we can dam up in the direct primary care model. We can keep and maintain and treat all that in the clinic versus referring it out for additional costs.
That's a great point, which kind of like, when it's so, I want people to kind of understand that it's not just about the clinic visit with the doctor. It's also that if you need, because, primary care doctors, you guys don't have a CT machine in your clinic. You don't have an MRI machine in your clinic. So when a doctor needs to kind of refer patients out to those types of services, talk to us a little bit about what you guys have put together as far as what we call a pass-through discount system, to where if you need to send a patient for lab work or maybe an X-ray or a CT or an MRI, talk to us about how you guys handle that.
Yeah, I'll take that one. We wanted to follow our patients that need the help, right? So we understand this model will attract some clients that don't have any health insurance. This might be their only component, and or you have those clients that have, again, large deductibles. So, you really want to focus on what's the spend under those deductibles, because that's where they're focused, right? So labs, imaging, CTs, prescriptions, et cetera. Like we will literally follow that patient and help them in terms of costs where they need to go. Not only in Dr. Libby's direction, here's where you go, but here are some options considering your financial situation of where you can go and where we've negotiated some cash pay pricing, if you will.
Excellent. That's really good. We're going to have an illustration here in a little bit about, how big of a differential, how big of a difference maker that can be financially, not just for patients, but also when we start to think about applying DPC as a delivery model within self-funded health plans or even fully insured health plans for people with insurance or people without insurance. We all know that health care is not the same thing as health insurance. And I think what's happened in our country is that we've all been led to believe that all healthcare is just so darn expensive that you have to have insurance for everything. And really direct primary care just really flips that on its head and says, actually, no, there's a lot of healthcare that people need and they need good quality access to, but it needs to be affordable. And we know that, from our work and through y'all's work, that a lot of healthcare is affordable. So we're gonna talk a little more about that later, and that's kind of just getting down to just a simple risk management rule. Pay cash for risk you can afford. I think most people in this country can afford a $2 prescription of an antibiotic, right? So why would you take out your Blue Cross Blue Shield insurance card to pay a $10 copay for a medication that you can pay $2 cash for? It's just it's counterintuitive. And I think that DPC really works on that mindset shift that you don't necessarily need insurance for good quality healthcare. What are your thoughts on that in general?
Totally agree. Again, DPC, if you're taking a more proactive role, you're fixed cost versus variable, and you're paying attention where you're going, especially if you have insurance, where am I going? Where am I spending that money? Right? You're just being a better fiduciary responsible person, but we're helping you do that. You're not doing that, on your own. Healthcare in general, for most people, it's so complex. Like if you're not in the game, so to speak, you don't know, you have no idea how this really works. Let's simplify it, right? Like it's not complicated. And to me, DPC takes away a lot of complication and simplifies it to a greater degree.
Right. So let's shift. That's a great point. Let's shift a little bit because I know one of the topics that comes up a lot, especially right now when everybody's kind of practicing the social distancing and things of that nature, is everybody keeps saying that this is like we're on the verge of seeing an explosion in like telemedicine and things of that nature. And certainly DPC has always had these components. This isn't something a virtual access to your doctor is not something that just cropped up in the DPC model because of COVID. Talk to the audience a little bit about your virtual services and how most times, maybe patients don't necessarily need to come in and how big of a value proposition that is for patients, especially remotely.
Yes, I'm happy to comment that there's a big difference between telemedicine and virtual care, if you will. Telemedicine is a wonderful option, particularly if you are in a pinch and you can't get in to see your doctor, then that's your last resort, or you're out of town, you're traveling, and you need medical care. It's a great option. What we're offering is something more personal. It's telemedicine in a way in that you can reach us virtually, but telemedicine is going to be with some doctor that doesn't know you, your medical history, they don't know anything about you, and they're treating you from across the country maybe or across the state, and versus calling someone who who has been taking care of you, who knows your medical history, and who treats you like a family member and can take care of your problem on the spot and kind of knock it out. So not every visit with us, we don't feel like you need to come in for every single thing, and a lot of times we can take care of it over the phone, through text, or through email, thereby reducing your exposure to other germs. I used to always say that a primary care doctor had job security because all they had to do was tell you to come in to see them, and if you weren't sick when you came, you were certainly going to be sick when you left. So there was definite job security. But anyway, we realize that medicine is consumer driven these days. We want to make things convenient and easy, and our model is set up for that.
Josh, I think that's a great point about being consumer driven, and like even at the clinic level, Deeter had mentioned early on our focus group study, and one thing that it pointed to, and most people on the call will, I think, relate to it very well, is even in the clinic setting, you know, how it just needs to be less sick feeling. It needs to be comfortable. It needs to be, obviously, I think most places are clean, but we can reduce the patient load because we don't have stacked waiting rooms, and just the environment, the culture. It does need to be very consumer and service driven, and these are just, these are small tweaks and services that you provide that accomplish that.
Excellent. So this is kind of just to wrap it up, the quality of care and the value proposition. I think that it kind of, all of that's, to summarize it, is it's just more valuable. It's better quality. And we've learned that, in order to reduce costs, which we're about to kind of get into, is the secret to reducing healthcare costs is improving quality, especially quality in the primary care setting. The old Chinese proverb, I don't know if it's Chinese proverb, but it says, an ounce of prevention is worth more than a pound of cure. And that's kind of like the way I see DPC, is that you have to, the more time we can spend on keeping people healthy, we don't have to spend near as much time and resources getting people well. And so that's the component that I think is wrapped up in the quality value here. Before we switch over into the financial components and the impact that DPC has with health plans and with providers, one of the listeners, Betty, she brings up a really good question, and she says one of the topics that comes up with DPC is, what if I need to be hospitalized, like go inpatient? Do you come? Does the doctor come to the hospital? Or will I be taken care of by a hospitalist? And I think that's a pretty cool question. So whoever wants to jump in and answer that one, thank you, Betty, for that question. That's a great one.
I'd probably go to the doctor on that one.
Okay. If the patient needs to be admitted, they would likely go on a hospitalist service. That is really the trend of medicine these days. The hospitalists are trained in hospital medicine, and it makes more sense from a time perspective. It makes more sense that the hospitalist is there all day and can handle issues that come up. Now, we, of course, will be in constant communication with the hospitalist because we want to know what they're providing, what treatments they have you on, and make sure that we can continue the continuity of care once you're discharged from the hospital. But the care would be likely passed off to a hospitalist once the patient needs to go inpatient.
Okay, thank you. Okay, guys, let's. This is all really good stuff. I appreciate it. Let's transition a bit and talk a little bit about the financial impact that DPC has on patients, as well as employers and health plans that integrate DPC into those health plans. Research shows that when financial barriers, we talked about the cost of healthcare, when you either reduce or you remove financial barriers to good quality healthcare, that downstream costs are also, and we've been talking about that, the reduction in ER visits and the reduction in unnecessary tests and prescription drugs and things of that nature. So, and all of that makes really a lot of sense, but PCP doctors are trained to manage a broad range of healthcare needs. So as a cost mitigation strategy, tell us how effective direct primary care can be and the impacts that it has on downstream. Where do you see the most impact for as far as a financial impact?
I honestly think one of the biggest ones here is if you can, and you're not going to eliminate all these, right? But like if you are more managing on the front end, so to speak, emergency room, for example, simple stitching, some burns. Libby might can speak a little bit more to that, what that would, really entail. But, for example, my wife had 3 stitches at one of the, ER, whatever, I don't even know the name of it.
Freestanding ER.
Yeah, one of those. And it was literally 3 stitches cost me $1,000. So that's the things that we can fix. Like, not everything needs to go to the emergency room. Like, again, like, you kind of take that quarterback of care mentality. Like, it all starts here. I'm going to call Dr. Libby. I'm going to find out, can you take care of me, or do I need to go? And I think most people, when it's that bad, like you're going to the emergency room and, you're skipping go, so to speak. But think about that. I mean, those average ER visits probably around the $3,000 neighborhood, versus a fixed cost, come in, get it taken care of, go home. Connectivity, it is going to drive down costs, but I think personally, like, that's probably one of the most significant scenarios for an employer, for an individual. If we can keep you out of any ER room, that's a home run.
Yeah, I know that's always one of the key things that a lot of employers talk about is how do we avoid the emergency room, and just because it's the most expensive entry point into our healthcare system, and we can't emphasize that enough as that quarterbacking of care. So you can see a lot of ways that DPC can financially impact the health plan or employer. And I wanted to kind of use this as an example. We pulled an EOB, an explanation of benefit, that and I find this very intriguing, because this is where you guys can speak more to the Medical Dojo business model here, is that as I start to kind of highlight, this is a preventative care visit. It's a pretty thorough preventative care visit. As you can see, a general health panel was conducted, an ECG was conducted, they pulled a lipid panel, urinalysis. So this is a pretty comprehensive annual exam. But as you start to see the charges, now granted, we know that insurance companies aren't paying full amounts on these charges, but even a generous discount of 50%, you can see how these things get billed at a very high rate. And when we apply, the Medical Dojo model, here's what I find really cool. And I think this is where a lot of people will see the continued value proposition of direct primary care. These are prices that Medical Dojo offers to patients for this exact same services. So when we see a total overall bill that in the fee-for-service setting, in the status quo setting, $530. And even if you applied a generous discount of, say, 50% off, that's still over $250. And so again, back to that person that's on a high deductible health plan, they're going to be out of pocket. They have first dollar responsibility, as to where in a DPC setting, it's less than $50. So these are what we call intangibles in direct primary care. So you guys talk a little bit. I mean, we talked about that. I don't think we need to cover it again so I don't want people just to focus on the actual doctor visit, right? It is not necessarily the cost of the visit, but all of the other intangible services, that are needed, like lab work and CTs and things of that nature. So let's see, you guys just talk a little bit about how you're able to, what you've done in the community with other healthcare providers that you're able to get pricing like this.
Well, Josh, I was just going to come back to your example you have there, because I think people can relate it to if they have a high deductible health plan. All this cost, even after whatever the contractual reductions are, that's still going, to your out-of-pocket deductible, and that's the $265 that you would pay out of pocket, and you do that once or twice a year. You paid for an entire year's worth of membership.
Yeah. Excellent. And that kind of leads into, another question that goes back to the panel size that Nolan, he's on the webinar this morning, and he's got a question. He says, the model sounds great, especially the reduced costs with higher quality care to the consumer, but how does DPC make money? How do you guys, stay in business? And then secondly, as a follow-up, if there are 1,000 consumers or patients on your plan, what does that do to wait times and quality? So let's start with the first one, your business model. I mean, people are just kind of curious as to how you're able to make that work financially.
And so it's a membership model, and we know, so whatever depending on where you fall, if you're an individual or family, we have that priced accordingly. And then it just, simply becomes a matter of knowing what our fixed and variable costs are and how many patients, we can see and spread that across, spread it across those costs with, obviously with some margin on there. We have to make a little profit to stay in the business. So it's not a super complicated model. It does, with all the value that we're presenting, it does seem a little counterintuitive. I was thinking about the same question this morning. I'm kind of a math guy, and I'm like, oh, it's just kind of hard until you just sit down and pencil it and say, this is, okay, that works. Like, we can make this work. If we see this many patients and these are our costs, this is what the fee needs to be. And with all the other side of the equation, like this EOB you just presented, it's hard. It's like a little bit like magical math. And then the second part of the equation is it's the same. So you just carry that a little further in the industry, in this direct primary care industry. You typically find that most providers, we talked to many of them, they operate comfortably within 600 to 800 patients per provider. And we've also been told and advised that that's pretty conservative, and we've found some running as many as 1,000. So, we're gonna keep an eye on that, and going back to, the benefits, the key benefits and what people need and from their primary care physician. We're just going to watch that internally. If we feel like we're not able to deliver the service that we've presented, that if we're not able to deliver, that's when we know we need to add staff. I mean, there's several mechanisms that we can watch, both financially and in service level guarantees, if you want to call them, that's what will tell us when we need to add, to our clinical staff.
Yeah, that's a great point. I mean, so I think that through the utilization of your virtual services and then also kind of limiting your panel size, that's how you're able to maintain the guarantee of same day, next day appointments and the guarantee of 45-minute to 60-minute doctor visits. So you maintain that quality component for patients. I think that's what I'm hearing you say.
Yes, yeah.
And then I'll just throw into, I mean, the concept of the DPC is not ours. It's out there. It's across the country. And I think you have a slide to show here in a minute that will show that it's, yes, I mean, this is a concept that's working across the country, and we're just a small town, and we're bringing it here. But you can see in the major metropolitan areas, they are using this model with quite a bit of success, and it's a growing trend.
Yeah, I mean, I put this slide up, as we kind of start to wrap up here and lead into our Q&A session here in a moment. This is a map that a website puts out. It's called DPC Mapper. And if you would have looked at this map a couple of years ago, there was not near as many dots all over this map. But DPC is a very rapidly emerging model. But as you can see, and one thing that kind of stands out about this map is that, we still live in a very, a pretty rural area. If you think about the greater, 26 counties of the Texas Panhandle and down into the Permian Basin and places like that, it's still very much a rural part of the country. And so when I think that's an extremely big value proposition, is that when you have those virtual capabilities, that people don't have to drive long distances to see doctors. So many of these smaller communities around Amarillo are coming into Amarillo, but this is something that, as you can see, is a needed a needed service in our geographical area. So do you have anything to add about that? As like, I think Libby, Dr. Libby kind of hit that on the head, is that this isn't just a unique idea that you guys came up with here. It's a rapidly emerging delivery system that's gaining a lot of national attention. So we're very, very excited to have it here. So
I would maybe add, Josh, real quick, of the doctors and the practices that, Elliot and I visited with, not one of them said they would go back in a fee-for-service platform. I mean, like the light switch went off, they got their life back, they got their own quality of life back, and they got to practice medicine again the way that they, again, like I think Libby said it earlier, that's what you went to school for. And that was really encouraging. And literally, like all these DPC practices around the country, it's kind of a cult, there's a lot of like openly shared information, best practices. Why are you doing it this way? Have you tried it this way? And I love the collaboration of the community. But to me, it was really telling, when you had those docs saying, I will never go back to the way it was.
Right. Yeah, I mean, the quality of life, that's a real issue. We didn't get to talk a whole lot about it today, but like doctor burnout is a real issue, and primary care is not one of those areas of medicine that a lot of young people are just coming into med school to pursue. And I'm hopeful that in the future, and not only as this is more and more proven as a financial model for these doctors, that it shows to be, really fulfilling for doctors, why they get into medicine. Doctors I talk to, there's a few, maybe some like really highly specialized surgeons that say, I got into this to make a lot of money. But I think it's kind of like school teachers. Most people get into this profession because they care about people. They want to deliver high quality healthcare to people. They want to make a difference and save people's lives. So I think I think this model serves that purpose very good. So guys, thank y'all so much for the information you've shared with us this morning. I know that we're extremely excited to work with you guys further to further educate our clients and prospects about this new model that you guys are bringing to Amarillo. Thank y'all again very much. As we start to transition into some Q&A, I just wanted to put up y'all's, tell us, we didn't get into the specifics, where is your physical location going to be located?
So the address you see on the screen there, 7659 Hillside. Most of you guys probably recognize maybe House Divided or 575 Pizza. We're in the shopping center in that area there. You see the phone number, 322-3656, also spells Dojo. And one correction to make is that email address is actually membership@medicaldojo.com.
My bad.
Versus membership.
We'll send out a correction. We'll send out a correction for you, Elliot, on that. Sorry about that.
Yeah, no problem. I know it's fluid, so.
Okay, so one of the questions that came up during the conversation that I kind of want to get to real quick, and we're gonna we don't have a set time period for Q&A. If y'all had some things that maybe I didn't touch on, I'm not a doctor, as Deeter pointed out earlier, and I'm also not a professional webinar host either. So if there was something that you guys wanted to get to that I didn't get to, feel free. But one of the questions that Lance asked is, is Medical Dojo a part of maybe a greater network of providers, specifically, if to cover for Dr. Libby, if Dr. Libby wants to take a vacation or something like that, how's that work? I'm sure you guys have addressed this.
Go ahead, I think Libby.
Well, yes, we at this time, no, we are not part of a greater network, but we do have experienced family nurse practitioners that are going to be on staff with us. So we will be sharing calls between us, and we'll just have to see as the volume, depending on how many patients we get. If the volume increases, then I'll bring on a partner, and we'll have other physicians, and we'll add on nurse practitioners too as needed. So it's just going to be pretty much volume based. We'll handle it till we can't handle it.
And we'll, like Elliot said earlier, like we're gonna pay a lot of attention to that because, you know, first and foremost, we are taking care of people. That's our first priority. But I do think, in a way, like we have a much grander vision, you know, for this entire venture for Medical Dojo, not just Amarillo. We're not even open, and we're entertaining South Texas has interest, Florida and Maine of all places. Like, and it's just from the people that we're talking to, but there's genuine interest in this solution, not just here. I mean, we want to focus here because this is going to always be our core. It's our home. It's where we live. And we think it's important to do this here. Otherwise, we wouldn't be doing it. But to maybe further, you know, answer Lance's thought, like we're building this thing to scale.
Great.
And I'll just add in too, as far as the call component of that goes. Of course, emergencies are going to happen, and that's unavoidable. But patients that are more connected to their primary care provider and who have quality time in the office with them, or on email or text or chat through the day, aren't going to be calling on those much at night. And I think that's what some of these DPC practices are finding, is that call's not terrible like it is in a lot of primary care practices, because their needs are getting addressed earlier. We are proactive in our approach to medicine. We anticipate things that might go wrong, and we educate the patients ahead of time. So I'm not anticipating that call will be a terrible thing. Hopefully I'm not wrong.
So another question that came, a couple more questions here. Oh, I'm sorry, Elliot, did you have something to add to that?
Just a joke. Like I said, I can take a couple calls.
Yeah.
I went to Garden City Community College. I'll take a couple.
Right. So one of the questions that came up are these services available now, or when is your official public launch date?
We're doing pre-enrollments now. July 1 will be the hard open. We are doing, like, you know, pre-sales now and actually doing enrollments. So, but July 1 will be the actual grand opening, if you will.
Okay.
Of the dojo.
Why the name Dojo? I know that we've kind of, you know, talked about that in the past. You know, what was the inspiration behind the term Dojo?
Well, originally, you know, Elliot and I, we always have these fun, interesting conversations on maybe it's a new business idea or venture, right? And it's like, I said, I don't want to name this thing XYZ Doctor because that's what everybody does. I don't want to be like anybody else. I don't want to have some fun with it. So we came up with Medical Dojo. Dojo, by definition, is place of the way. So that had a deeper meaning to me, like, okay, your care starts here, and all the answers are really right here, right? But Medical Dojo is fun, and so the first time that we met Dr. Libby, she comes in, and like we you know, we knew, like, okay, this is perfect. Like, we love Libby. She's infectious. She's fun. And she said, well, you know, what are you guys naming it? I said, well, we're gonna go with Medical Dojo. And she starts laughing, of course, like, yeah, that's funny. Who's going to open up a medical dojo? Well, me and Allie are like, we are, because we think that's pretty cool. And she said, I got to think about that. And so me and Allie are like, well, that was cool. That's not going to fly. So we had a meeting the next day. Libby comes in. She goes, I love it. I'm in. Wouldn't you agree, Lib?
Yeah, absolutely. It had to mull around for a minute, and then it stuck. And no, I love it.
Excellent. Well, that's a fun story. It's interesting. Here's another question that came up from Dion that's on the webinar this morning. She says, from an employer standpoint, we need to address having our employees covered if they had to have a hospital stay. So do companies, and I'm happy to take this one if you guys want me to, but do companies usually have a separate policy for this if they choose Medical Dojo? And so if y'all don't mind, I'll take the first run at this one. Dion, it's a great question. Thank you for asking that. And yes, we are not suggesting that direct primary care replace comprehensive medical insurance. We fully recognize that DPC doctors are primary care doctors. They're not cardiologists. They're not neurologists. They're not, they're not specialists. And they're certainly, they're not a hospital setting. So Those are very expensive things in healthcare, but they're pretty rare. Hospitalizations don't occur very often. So a lot of times we are seeing employers that are coupling direct primary care with, so let me take a small company that's fully insured. A very popular pairing that we talked about earlier is pairing direct primary care with a high deductible health plan. So you have catastrophic coverage, you know, for big things like a hospitalization, a surgery, a premature babies. Absolutely, we encourage people to have a separate policy or things like that. That's why, you know, we kind of help. That's where Butler Benefits can come in to help your organizations. But as we know, and as we look at the data and the research, for people like me, 100% of my medical needs are captured by a primary care doctor. Now, granted, if I get hospitalized, I'm going to need something there to help me cover the cost of that. So we pair direct primary care very frequently with certain types of insurance policies, but then we're very excited to announce for some of our smaller clients, we're going to be, and I'm not going to advertise this much here today, but have the capability to take medical dojo services and pair them with things like Christian sharing ministries, things like Christian Medishare or Sedera, or, you know, some things like that, that have proven to be very, very good combinations for comprehensive care. But we're certainly not saying that people should go out and cancel their comprehensive major medical insurance and replace it with primary care, because if you do need those specialist or hospital inpatient stays, you're going to need probably some insurance for those things. Another question that came up is what willingness, and this is from our buddy Jared Fuller, thanks for this question. What willingness have you seen in patients to leave their current physicians for your for this model and for your practice?
Well, I'll take a little bit of that one. For a lot of the practices that Elliot and I again visited with, they were traditional practices, and then they converted their practice to DPC. I think the conversion rate, you might chime in, was literally around 80%. They had a very high turnover rate of their current, you know, traditional fee-for-service, I have primary insurance, to I'm now not on that, I'm on a membership. Was there more to that question? I feel like I'm missing.
Yeah, well, I think what I kind of heard, and correct me if I'm wrong, but people that are happy with their current primary care providers, that's wonderful. We're not encouraging people leave their primary care providers if they're happy. There are numerous people in the Panhandle that don't have primary care, and they don't have a quarterback that is negotiating, you know, their care. And so we are there for that. Now, there are also a lot of people that have a primary care provider or a primary care network that they're not happy with. They're not getting their needs met, and we want to be here for them as well.
Yeah, I have a primary care physician, and I'm not great at it. I'm about to get a whole lot better at it, at being a patient and being more involved, but I don't have a relationship with that doc. Like when I go in there, it's very impersonal. Like he doesn't even know my name's Deeter. He calls me Jay, which is my legal name, which is fine. But like we don't have any relationship, you know. And again, like I think really honestly, by doing it this way and creating a real relationship, I think people are going to love it. I can tell you that.
Yeah, I'll just add, we're not converting the practice. I mean, we're starting with patient zero as not in that sense, but we're not converting the practice, so, you know, it's.
And I know pediatrics alone, haven't been a whole lot of new pediatricians come to town in the last 10 years. And I know of people who have had newborns and have tried to get in to see a new pediatrician, and well, a lot of them will take newborns, but if you just move into town and you have a child, getting into a pediatric practice is very difficult in this town. And most practices are pretty much maxed out. So I think that we will be of benefit to people with children for sure.
One thing is for sure, it's never a bad thing to have more primary care doctors in any market, especially in West Texas and things of that nature. So, I understand, we understand as well that a lot of times in the employer setting, as you're thinking about integrating direct primary care as maybe an employer-sponsored benefit, so there's a lot of ways that employers can approach that as well. We do have some clients that are willing to say, as an employer, we want to pay for this. We want to pay this monthly membership for our employees in order for them to have access. Some employers don't go that far. Some employers say we want to make it a voluntary option and things of that nature. So to Dr. Libby's point, we're not encouraging people who have a good, solid, established relationship with the primary care doctor. We're really speaking to the people that are a little bit, maybe they're disgruntled or, with their current providers, or just it's an impersonal relationship, to Dieter's point, or they don't have a primary care doctor. It's extremely important for people to have access to primary care in this country, because it is not just a quarterback for high value care. It is a cost mitigation situation where, as people have comorbidities and chronic conditions, they need someone to be able to talk to be able to help them with life coaching, lifestyle coaching, risk management, all of these things that lead to healthier, happier people, healthier, happier employees. And it's just, I think that it's a big part of solving some of our issues in healthcare. And overall, we hope that we get that message across to everybody. Well, do you guys have any other comments? The questions have kind of slowed down and I'm out of questions. Is there anything that you guys wanted to hit on that we didn't talk to? If not, we're just going to kind of wrap up. And of course, we recorded this session. We're going to make it available to Medical Dojo and all of their patients and clients as well. And then, of course, we'll be sharing it with our networks and our clients. But thank you guys again, Elliot, Deeter, Dr. Libby. It's been a pleasure. I know that we'll be hearing a whole lot more out of Medical Dojo, and hopefully everybody got something out of this.
Thank you.
Thanks.
Thanks, Josh.
Josh.
Talk to y'all soon.